Okay, good morning, everyone. Thank you very much for coming. It is lovely to see that there are so many people interested in public health and early career researchers. I didn't know. I'm Anna Violeta, I'm a research associate at the Department of Public Health, and I will be chairing the meeting today. And I will start immediately with Dr. Erica Jane Cooper. She's an associate professor in health psychology and public health specialist based at the University of Bedfordshire. She's a senior advisor to Research Design Services and public health research applications and design advice, and supports potential applicants who are interested in applying for commission calls to develop applications to the NIHR Public Health Research Program.
Okay, hi everyone. Okay, so I was asked to prepare a session to talk mostly about what Research Design Services, who they are, what we do, and how we can support applications. But also I want to gear this a bit more broader to think about what some of the funding potential is for early mid-career researchers, and to think perhaps a little bit more longer term to what some of the more prolific sort of research pots of money, and perhaps how you might be able to tap into that as well. So thinking short and long term. Okay, so just some quick facts about the National Institute for Health Research. You may already know much of this, but it's the largest clinical research funder in Europe. So it holds a lot of money. It's obviously very prestigious funder. And in terms of the amount of spending, there's lots of money, basically. And in fact, many of the funding streams are underspent. So they're not spending as much money as they expect to spend. We certainly find that for public health research, and I'll talk a little bit more about that. So this is not a funding stream that doesn't want to spend money. They want to fund good quality research. So I guess our job is to make sure you can do that. So some more facts about NIHR. So success rates are normally 10 to 20%. When we talk about success rates, we talk about first entry applications, and I'll talk a little bit more about that because each funding stream is quite different, but normally they will have two stage applications. The success rate normally for a stage 2 is much, much higher. Okay, so this is just at the first entry, and that's good because sometimes it's about what the funder's looking for, but normally very, very high success rate when 50, 60, 70% in some cases after getting through to stage 2. Some potentially higher than others, and again I can talk a bit more into that as we go through. They also pay full economic costing, and I don't know if any of you are familiar with full economic costing. You may well be, but it means that they pay a proportion of the additional costs that universities require in terms of time. So universities generally like this funder. It keeps everyone happy. The interesting thing about NIHR and the different types of funding streams is that there's different types of so you can go for your 1.5, and some have unlimited funding, but you also have your lower stream funding. So there's lots of entry points into getting there, particularly for early career researchers. When you want to be a principal researcher and have your own grant, that's a great way to tap into that, and that's exactly what NIHR expect and want to happen. What they're interested in is research that has real impact. Okay, applied research that has impact, and very much it's about selling that idea, and it's conveying that to an audience that don't know your particular area. And we'll think about what a strong application looks like as we go through. Normally project teams usually comprise of a mix: academics, practitioners, and service users. Service users particularly are very important to NIHR. Okay, that public involvement is crucial, and all of our advice focuses on: have you done your PPI work? What work have you done? How have they informed that, and how you can really oversell. A lot of the applications I see is people underselling their research. Oversell what you've done. Yeah, all the hard work you've done, all the people you've engaged with, So they're really looking for that multidisciplinary approach. So something to think about. So these are the main funding streams. So We have public health research. I know public health research quite well now. I've observed quite a few of their funding panels and their prioritisation panels. I'm quite familiar with what they like, what they don't like. I'm perhaps a little bit less certain of HTA. I know that HTA are very much more centred around large RCTs. Health and service delivery. Again, this is more about applied health and social care research. So research that has impact in her health service delivery. And the I for I, so that's more of your technology aspects. So within HTA, though, what we do have is research for patient benefit programme. So just out of interest, has anyone sort of come across this funding programme? Okay, have you applied?
Yes, but probably wasn't the right funding stream. So,
okay, yeah. So a lot of the, so that is actually, it's interesting you raise that because that is actually a common issue, is that sometimes it's not very clear what funding stream is the best for your type of work. What I suggest in them situations is a one-pager to the funding panel, the funding team. They will normally look at that and normally be able to scope that. I certainly know that that's the case for PHR, who don't fund NHS interventions. Now, this is always problematic because some interventions that are in public health are funded through NHS and it's not always clear cut. So we always suggest go straight to the funder themselves. They'd be more than happy to look at a one-pager, a brief outline of what you're trying to do, and they'll tell you if it's in scope or not. If it's not, they will direct you to where it's going to be in scope. So they will offer that help and advice. The interesting thing about research for patient benefit programme is it has good success rates, okay? And it's an excellent place to get a study done before you go to HTA. So if you're looking to do an RCT, you want to do a feasibility study, a pilot feasibility, something around that, you could go there, do a tier 2 study, and it's a successful feasibility, you will stand an excellent chance of going through to HTA. Okay, so or PHR, depending on. So it's an excellent entry. And I certainly see from PHR, if you've gone through how they see it, a progression, they're very successful. In fact, I think, I can only talk about the panels I've observed. In fact, everyone that's gone through a feasibility stage with NIHR or with the MRC has got through. Also, though, there's tier 3, and I think that's particularly interesting for early career researchers because this is, this is where they sort of say, go for it, be a PI, demonstrate your research. And gain research impact through tier 3. So this is more of your intervention development work. So you can easily see, right, how you go from tier 3 to tier 2 to HTA. Okay, so it's a great trajectory if you're looking for research funding. There's also lots of fellowship programs which may or may not be used, and certainly we do a lot of work around supporting people like vivers, pre-vivers and stuff like that. They can be quite scary experiences, but excellent opportunities if you can get through. So there's lots of other sources of research funding. So I don't want to come here and say NIHR, only go to NIHR. There are other sources of funding, and particularly in public health research. I'm going to talk a little bit more about the Medical Research Council because they have a very interesting funding stream for, I think, early career research is quite suited for that. So yeah, so don't feel like you have to go through NIHR. There are other sources. Okay, I'm just going to talk a bit more about the PHR programme because I know quite a lot about this programme. The one thing I will say is it's very much centred on the evaluation of existing interventions. Okay, so it's not intervention development work. They will fund some intervention development work on some commissioned calls, but it's normally where you just want to adapt it to a population. They want something that's already in place. as I mentioned, it's about non-NHS interventions. They say there's lots of other funders that will fund NHS interventions. We're not interested in that. We're looking at non-NHS interventions. What they're looking for is something around, the idea that it's going to improve health inequalities. They're looking at something population level. We think about what population level might mean. They will fund feasibility studies. Now, I always say it has to be value for money. I recently reviewed a commission call that put in 1.5 million for a feasibility study. I'm like, I'm not sure that's good value for money. So I think by all means, justify why you need that feasibility study, but make it good value for money. And think about the longer term. If at that stage you're not going to produce that generalisable evidence that they're after, what is that trajectory? They will fund secondary research as well, although in my experience that's less commonly funded. So I think there might be other potential avenues for research that are better suited than PHR. PHR, in my experience, they like existing interventions, evaluations of them, clear cut. That's my experience of them.
What do you mean by secondary research?
Like things like systematic reviews. Yeah.
Can I ask a question about non-NHS interventions? If it is an intervention has not been funded by the NHS but is carried out in an NHS setting, how does that?
I guess that's fine. And I guess their argument is, who does it benefit? Who does the intervention benefit? Is it public health or is it the NHS? And if you can justify it's public health, then they will be happy with that.
I feel like it has benefits for the NHS out there.
Yeah. So like I actually put in an application recently, and it was about a service, counselling service for parents who have pregnancy loss. And that was carried out in hospitals, but part funded by NHS and part funded by charity. They were happy with that. And so I do think that there's some flexibility with that. If you can prove that it's not 100% funded by NHS, I think there'll be. And what I always say is, we offer service, come to us if you want to have that discussion in detail. We can also go to the programme team ourselves with a one-pager of the intervention, and they'll say yes, no. And if it is NHS based, then there are other funding streams for that. So the answer is not going to be, no, that's it, end of the road. Yeah, so if you're not sure, come to us is what we say. So public health research programme, they have your researcher led, so you go in and you design that. So they have that funding stream. They also have what we call commissioned calls. These are a little bit more diverse, different, but I definitely think keep an eye out on these, because you never know when they come out and they think, oh, look, funny enough, I was just doing an intervention related to that. That means it's a high priority area for them. They want to fund that work. So keep an eye out for the commission calls. They also have a fast track scheme and a rapid funding scheme. I'm not going to talk too much about the fast track scheme, because actually the fast track scheme, I think, disadvantages applicants in some ways. It basically means you miss stage one, but I think stage one is crucial into getting to stage two, that feedback that feeds into stage two. So I generally avoid advising people to do that unless they have been told to do that, which sometimes happens if, for example, let's just say you had a feasibility study with PHR, they might say just goes to stage two. That's fine. You've had that experience with the funder. I wouldn't normally advise them. Rapid funding schemes, again, they're less common, but they will fund small pots of money, and I'll talk about that a little bit. 3 deadlines per year. I think this really attracts everyone. There's no upper limit. Everyone says how much money is a good value for study. It's like if you have to justify the value in your study. Normally, a large evaluative project like research would normally typically be 1.5 million. I think more than that, you're going to really have to justify that. Okay, and applications can be led by researchers based in the UK, so not UK. Not allowed
Can I
to.
just ask you on that? I work for a UK Health Security Agency, and previously some of the research councils wouldn't let Public Health England, which was our former, what we were before they changed the name, apply for some of their grant fundings. Is there any restriction for government agencies?
Yeah, I think there's some restrictions on the institution that you work in, so it is worth clarifying that, because I have a sneaky feeling that might differ by funding stream. But generally, I wouldn't like to say that I know in that exact instance, but I know that, in different public services, that's fine. I know universities fine, but I wouldn't know of other particular constraints. But yeah, something to worth thinking. Yeah, you can always come back to us and we can go to the funding team to check. I won't talk too much about the rapid funding scheme, because this is where you think that an intervention is imminent. It's a bit like a policy level intervention. Let's just say they're going to reduce the cost on something, or they're going to change the emission levels in certain areas. But actually, we need baseline data to be able to check that. This is time precious. We need to do that. That's exactly what this is after. Okay, so you have to say this is time imminent. This is, this needs to be done now. And if you can justify that in a 2-page summary, then they will. And normally they're expecting a full evaluation to come through. I will say, if you get through this and they submit that, then it stands a very good chance you're going to get that evaluation project. I think so. I wouldn't like to think otherwise. So it's very much population based, and it's looking at upstream, not treatment approaches, if you like. So it's more around whole system approach. Yeah.
I'm just curious how the population health focus links to the focus on interventions, because there's a lot of determinants that we can explore, but we don't have when we can't make the policy, for example. So how does an NIHR see studies that can explore the determinants and kind of put forward almost advocacy recommendations, rather than something that is an intervention that can be tested and will benefit patients? I just wonder if you had enough of those through the system.
Yeah. How we define populations, they always say that they're interested in subpopulations. So they're much rather that you focused on a particular population than you are on the whole population. So you can hopefully disentangle some of what you're talking about there. Also, when we think about population level, it is at different levels itself. So we could think of that as a community, we could think of that as a region. So they're interested at that subpopulation. So particularly focus on health inequalities. So if you're particularly focused on particular older groups of people, coastal areas, particular sections of interest in that area. So I think that speaks to some of that. And then also they like data linkage from lots of different sources, and they like that you can be able to do that, to give that more robust evaluation from a whole system approach, rather than the traditional RCT. Here's some questionnaires, here's some clinical measures, this is effective. You're not going to be able to do that at population level. So it's how do you find that data around you to be able to gain that evidence? So yeah.
Do they allow clinical practice research database research? So CPRD.
They also, they would do that. And I'm just thinking some of the data linkage studies they've done, like we just had a population one that looked at the London emission zones, and they're going to schools and they're paid for researchers to go into schools and to take oxygen, and then comparing different regions, so they're paid for that sort of funding as well, to gain data. But then if you can match that, for example, with other clinical data, even better. So there's lots of avenues there.
So if you were able to get a CPRD data set, link it to HES data, link it to
That's exactly what
infection
they
data, etc., they would like that sort of.
Yeah,
That's
absolutely.
good to know.
Now, and then you would have to demonstrate that you have access to that data, how that links, and sometimes that can come as a feasibility phase. Yeah. That data exists, that you can match it, and that it provides the evidence you want it to. Okay, so thinking about the PHR program, how does that work? So you submit an application, they will give you an initial remit and competitiveness. Normally they'll let most of them go through unless it's completely obscure. And then it goes through what we call a prioritization committee. Now, these are an interesting beast of people. I've observed them a few times. They are public health specialists predominantly, okay, and they're there to check for value for money, and is this evidence useful? So impact and value. What I will say is that they don't see your whole application. So part of what we say is you have to thread the importance and all of them aspects through your plain English summary, through the rest of your application, to make sure that they really understand that. Sometimes they're not allowed to think about methods, although sometimes they do, but sometimes they don't have the whole application to be able to make them comments. But that's why our service is quite good, because I think we understand what they see, so we can help oversell your work, if you like. Then once that's successful, that'll go through to a stage 1, and then that would then go to a stage 2 funding panel. And then hopefully you get lots of money.
I guess, does this apply also for the fellowships? For example, the launching fellows, is it the same?
No, the fellowships, I don't think they'd put you through all of that for the fellowships. I think that's just a one application process. Although research design services would be better, I think different people in the RDS specialise in different types of funding streams. So what if you're interested in the fellowship, you come to us, and then we would put you in touch with someone who specialises, who observes their panels.
Okay.
So yeah,
I will come.
no, definitely, that's what we want.
I'm just going to ask about the doctoral fellowships.
Yeah.
Do you have to specify whether it's going to be like public health or health and service delivery? Because I'm not quite sure. Or you have to specify that as the applicant.
I think you have to specify that, but it's sometimes read into what they're after, because I think sometimes it's saying a language in the way that they want it. So yeah, I think that's probably something that we'd have to discuss with you in the context of your work. Yeah.
For the RDS.
Oh yeah, RDS, yeah. And they support you pre-stage all the way through that. So yeah, so starting in conversations early is really going to help you with that application.
Thanks.
So as I mentioned, this is the first hurdle. So they're not coming from a methodological, they don't, very often they might not have that research background, but they are interested in the impact and is it important. And burden on the participants, they're very, they have a lot of public representation on that panel. So think about that as well. I guess it's a question of, if they had this evidence, would that be useful to you as a public health practitioner? I think that's what they're really trying to get.
Now that PHE is kind of fragmented into various bodies, are there representatives of all of like OHIV and UKHSA, or is it less than UKHSA because this is not so much?
I think it's a fun, they try to get that diverse, yeah, and different types of experience, and it's I think, and also they will have specialists come on board. So let's just say it's a commission call, they might have specialists related to that commission call as well. So yeah, it'd be quite a varied group of people that they like to think is representative of public health. So as I mentioned, they don't see the whole application, so it's really about how you make best use of your application to make sure that, you know, they view it as important. And then they're asked to score on this trajectory, and what you're looking for is a score of 3.5 or above. There are occasions where sometimes you might score a 3, and then after they go back and benchmark and they might push you over the hurdle. They generally favour rather than take away, if you like.
We take a quick snap of the slide.
Yeah. So in terms of what they're looking for in terms of an application, I guess these are really generic things that we speak to for all applications. So we're looking for something where the design, the detail, the justifications, the awareness of, you know, how your evidence fits in with the whole field of evidence, and this idea of PPI embedded throughout. So it's not just a, you know, we will have PPI, it's how have they informed it and what aspects of, you know, speaking to that throughout your application. These outcomes were, you know, deemed important to public input. But there's some more specific things to PHR that you might want to think about. Okay, so the team, they like public health people being on the team. It kind of says, you know, that they're interested, that this is important for them. So local authority representation, or if that's not relevant, other stakeholders. The intervention itself, I guess it's a really tricky one, because normally local authorities will implement, for example, an intervention or a policy level intervention. You might not have designed that intervention, so then you have to then justify the relevance and its use, and that can be quite tricky. And sometimes it's hard because it might not be on many sections of the population, for example. It might be one local authority doing something completely different to that local authority. I think the panel understand that quite well, and they understand that RCTs are normally quite difficult to do in public health research. So they are adaptable to sort of more different approaches to gaining evaluation data. So yeah, justifying the need, the importance of the question, potential impact on the health inequalities, that's really important. Pathway to impact, so thinking about, you know, they're thinking about it in terms of commissioning and how that influences public health practice more generally. Appropriate outcomes, so generally the primary outcome we say normally has to be health related. Sometimes that's tricky, so we have all sorts of applications, like from police, you know, to engineers, to all sorts of different. And sometimes the most straightforward outcome that they're interested in isn't health related, but they are looking for something health related. So it might be like a health and well-being related, so well-being. So they want to see that as a primary outcome, and they want to see a justification of that primary outcome. Feasibility and a logic model. I don't know if any of you have come across a logic model before. But this is very unique to public health research, and it's quite an important component. And a logic model, I'll show you what that represents, but it's understanding the theory of change behind that intervention, the mechanism of how that works. So, as I mentioned, PHR understand that RCTs are not always suitable. So they do things like natural experiments, and I know that even Cambridge themselves done the recent UK soft drinks industry. So you've got some great examples of how they have funded public health research and how they've done that for policy level intervention. And I'd say that that's exactly what they're after, or more localised interventions that have clear impact on health inequalities. So don't be shy in making a case for a non-RCT. They will ask for a comparator though, and you will have to justify that comparator. And again, our service can support applicants to think about what a good comparator might be.
I'll just ask you what you mean by the cost-effective component. Are you saying that you have to do a cost-benefit analysis as part of?
They generally like cost, the cost evaluative component of the intervention, that would definitely be seen in your favour. If you weren't, they would like to see a justification, or it might get picked up at stage 1. I don't think it would be a complete fail, but I think that they would recommend that.
I'm just wondering how qualitative research fits into this. So
Yeah, absolutely. So
like, would they fund just a qualitative project, or does it have to be?
yeah, if you could justify that that's valuable and useful, and in some cases, you know, that's where you can do. It might be a realist evaluation or a process evaluation of an intervention, or you can embed that throughout. So you can have like separate work packages where qualitative will fit into that, and they have funded that. So this is just a logic model. There's lots of different versions of logic models, but it's just the idea that you're evidencing how an intervention works. So someone might come to me and they might say, well, we're going to do a community connector, we want to evaluate that. And I'm like, but what are the intervention ingredients that make this successful, and how does that translate into impact? So this is an excellent way of trying to understand and unravel that. And there's lots of sort of evidence and support around logic models, and certainly we can point you in the direction of resources. That's helpful. So I'll probably finish in a few minutes, but I'll say that if you haven't got NIHR experience or PHR experience, then come to FADA, and I'll talk about that a little bit. We're the public health specialists, mostly because they're very unique in what they want, and a lot of people are like, well, it's got funding elsewhere, I don't need to go through them, but they're just a different beast. So we always say, look, if anything, it's going to help. It's not going to take away anything. Just engage with us. If you're not an experienced PI, you can go as a co-PI and in a mentorship capacity, and with justification, that's absolutely fine. If you're developing, you want to develop an intervention, then go through MRC Find. Now, we often find that interventions that go through that get funded through PHR. So again, an excellent route for you as if you're an early career researcher to go get your intervention developed, then go and test it with PHR. You're going to get the right people on board, but yeah, we definitely see a good success rate there. And in fact, that's the trajectory that they like. And I've just provided some brief details around Find. But again, you know, RDS will also support with this funder as well. We don't just support with NIHR. So that's worth bearing in mind. So I just want to end by sort of saying what sort of help and support, and I guess we can help with everything. We all sort of have our own expertise and areas that we focus on. So we generally don't just have one advisor, you'll generally have 2, and then we're normally, so like when I review a PHR application, I might get health economy input, I might get PPI input, or, you know, so there's different expertise within that system. We can also help with things like finding the right funder for your work, to helping with the design, and helping, you know, we will review applications as well. So yeah, so we can also support with costings. What we can't do is write your bid, as much as we'd love to, but and we can't help with self-funded sort of types of studies. But yeah, definitely we can do all of the above. And just a brief mention, because I'd be rude not to, is to talk a little bit about the service that I support. It's a national service, public health research application service. It works a bit like the RDS, but it's just specialist in that we just specialise in public health research, and we support all the commission calls. So normally they're quite diverse, very different in what they're asking for, and quite complex. And So we generally support all the commission calls. So we can work alongside RDS, so you can have both, or you can just work with us. Normally now PHR requests that you have a letter from us if you haven't got funding from them before. Yeah, but I mean, it's useful because we see their funding panels all the time. We're seeing what they like, what they don't like. I think that's useful. Things, and that's everything.
Thank you, Erica. So we have about 10 minutes for questions, if you don't know.
Can we have contact details for how we get hold of you?
Yeah, absolutely. Yeah, I should have put that on really. Yeah, and I should probably say with a caveat that for anyone who doesn't know, but unfortunately East of England RDS wasn't awarded the next contract, and the contract ends in September. Now, the narrative that I'm now presenting is that support will be in place. It won't be provided by us. Yeah, but there will be that support up until September. We exist in the form it is in now.
Yeah.
Will it be in
So let me go again. So as an international, I was just trying to figure out what funding opportunities there could be, and had challenges where you said can. One of the can be from the UK, so I was wondering whether internationals or what internationals.
They won't fund work that's done internationally, but they will fund international co-applicants. Again, with a justification, we do see that happen, particularly for, let's just say, for example, that there's an intervention that works amazingly well in a certain country, and you think that intervention would work really well in this country. That's the sort of thing they would offer that adaptable 6-month stage for. And then that would be an excellent example of why you've got an international co-applicant. So I definitely say that's something they're very interested in.
My understanding was that your nationality doesn't matter, but where you are being hosted.
Yeah.
Yeah.
Yeah. So as long as it's the intervention being delivered here and you're in the organisation that you're working for is UK, then you're eligible to is that right? Yeah. Yeah. Answer your question.
Yeah, just because for example, some PhD funding, it depends on the nationality. Yeah.
No.
But
And absolutely not. And they review a lot of their applicants. Like whenever I'm a co-applicant or something or a PI, we say they're looking for my data to make sure that there's equal opportunities for all. And that's something that's quite important, I think, to end the job.
So you told us, Erica, that the PHR is interested in qualities. And I wanted to ask you, is it like they want this aspect to be integrated in every project? So would you encourage people to work together, like when they think about a project, to work with people who work on health inequalities?
Yeah, absolutely. And that's that diversity of the team is really something that they like. So it's not just methods, expertise. It's that different thing that you're bringing to the table. So the health inequalities aspect is really important. And something that's become recently really quite important is sustainability of research as well. So thinking about that and threading that in your application. Yeah.
Do you mean sustainability in a sense of environmental sustainability?
Yeah.
Or do you mean sustainability as in maintaining the intervention?
Both. Yeah, both. I mean, so it might be things like, how the impact on the environment and how you can reduce that. So things like online meetings might be something to think about, or the intervention, the fact that you're doing that digitally perhaps has less impact on, other things. Yeah, so it's just thinking a bit more broadly around that. Yeah. And I mean, you only have a set amount of words in your stage 1. So I say just spread something in somehow, and then your stage 2, you can speak a lot more to that. Yeah, but definitely my advice is, you know, if you're interested in any sort of funder, you're at that stage and you're thinking about it, come and contact us now, because this is the right stage. No, we have so many people that come to us, you know, 2-3 weeks before, and I'm like, well, we can't do anything at this stage. And it's like they've already, you know, they submit, you know, they give us a draft and we're like, it's nowhere near ready. And that's not an issue, because we say, you know, don't go for the commission call, delay, because it's still a priority interest for them. But often they ignore me. Yeah, so getting that polished application takes a long time. So come to us early, you know, yeah, that's my biggest advice, if nothing else to do. And I'll pass all our details over, and they can get shared along with the slides.